Hello, everyone. Thank you for attending today's webinar, End of Discussion, How Your Organization Can Move Forward to Actively and Effectively Address Maternal Health Equity, presented by Wildflower Health. I'm Liz Wesky, and I'll be moderating this webinar. Our speakers today are Dr. Nwandu Onyoku, Chief Health Equity Officer of Providence Swedish, and Dr. Bhairavi Parikh, Chief Operating Officer of Wildflower Health, and Erica Johnson. You can read their full bios on the left side of your window by selecting the Speakers tab. Just a few technical notes before we begin. The webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please ensure that your volume is all the way turned up. This webinar is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentations with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. Okay, now let's begin. Erica, please go ahead.
Thank you so much. On December 7th, 2021, I was on the receiving end of one of the most heartbreaking phone calls I'd ever taken. My sister Luana had approached her 27-week of pregnancy and had just been informed that she could not carry baby Caden to full term. The only option presented at the time was to deliver Caden via emergency C-section. I answered the call. Luana was inconsolable. She was crying and begging and pleading, please don't take him. Please don't take him. It's too early. My sister rarely cries, so to hear her heart break over the phone like that was the most helpless I'd ever felt. Now, this was my sister's second pregnancy experience. So in December of 2019, she gave birth to twin girls, Erilyn and Skylar, and the first pregnancy was normal, healthy, full term. But the second pregnancy experience with Kaden was the most difficult and challenging for her. Now, leading up to December 7th, Luana had already experienced multiple blood transfusions and bone marrow procedures, all in attempts to understand why her blood pressure was making drastic and sudden changes and why her blood levels were continuously low. Now, keep in mind, all of these tests and procedures and attempts were done to no avail. Luana's questions went unanswered. She'd made many requests for her physicians at the time to connect with a prior hematologist that she had seen for a knowledge transfer, and that never happened. And to be quite frank, her case was passed around from doctor to doctor. And so, as you can imagine, there were a lot of emotions evoked from this: fear, frustration, exhaustion. But fear was the most primary and like driving emotion that I remember. There was always a constant fear of, am I going to lose my sister? Or am I going to lose Caden? Or God forbid, am I going to lose them both? Caden was born on December 7th, 2021, at 1 pound, 11 ounces. By this time, we'd hope that Lawana's health episodes would improve, but things only got worse from there. After Caden's delivery, Lawana experienced multiple infections at the site of her C section scar, which required her physicians to go back in, recut her, drain out the infection, and clean the wound. Now, this, of course, stalled any progress that Lawana had made prior to, and of course, brought her total hospital admission stay to 4 to 5 times in the span of 2 to 3 months. So, as you can imagine here, there were a lot of different feelings. We felt as if Lawana was generally unheard, disregarded, overlooked, and frankly uncared for throughout the entire experience. So, where are we now? Lawana's recovery and care is continuing, of course. It's a long road. It's been a long road to recovery, and part of that is because of all the simple progress that she would make, and then it would stall because there was another health episode or another test or another procedure or another infection that would come up to stall any progress that she made. Luckily, this time around, she was able to get to a great team of doctors that are developing a plan of care around her action, or excuse me, a plan of action around her care. And, right now they're in the process of planning for a procedure to remove a tumor that had developed in her abdomen. So, we're still definitely on that road to recovery and still trying to sort through and figure some things out. But hopefully, we're very hopeful that within the next 2 months or so, we'll have some great news to share, and Lawana would definitely be on the mend of things. Caden, of course, is doing great. He was released from the NICU in late March, early April. And as you can tell from the pictures here, Erilyn and Skylar are very much so excited to be older sisters. So they're showing him all of the robes and, keeping him up to date on the latest nursery rhymes. So there's a quite busy house that we have here, but we're very excited to have everyone home for now. So this was just one tiny snippet of an experience. But the sad part is that this is all too common for many people. Adrian Moore, Tamikia Miles, Brittany Miles, Jamisha Collins. Who are these people? Who are these random people, right? No, these are not random people. These are family members and friends that I know of directly in my circle that have had very difficult and traumatic pregnancy experiences. Adrian's daughter, second daughter, Araya, was sadly born still. Tamikia coded several times while delivering and had to be resuscitated. Brittany Miles had a very similar experience to that of my sisters, and her son spent several long months in the NICU. Misha gave birth to a beautiful baby girl and unexpectedly passed away in the hospital 2 days later. So I'm relieved and I'm glad that my sister was not just another woman to die, but it is incredibly, incredibly sad that she joins a large group of women that can bond over traumatic pregnancy experiences. Now, I want to take a step back here and just and visualize something. So I want you all to imagine when you yourself or you found out that a loved one was pregnant, right? Remember all of those exciting emotions, right? The tears of joy, the laughter, all of the excitement, and in the instant planning mode you probably went into, right? Now, consider and imagine those wonderful emotions and wonderful feelings that you've had being overshadowed by fear and uncertainty. Because for most people, the first thing that comes to mind when a loved one says, "Hey, I'm pregnant or expectant," especially in some of these experiences that I've had, the first thing that comes to my mind is, "My God, I hope she doesn't die from this." And so I've been trying to grapple with the fact, how can such a life-giving experience be a matter of life and death? Thank you all so much for listening in.
Hello, good morning, everyone. Thank you for that powerful story. I think we probably just need to sit with that for a minute as we continue with this conversation. My name is Dr. Wando Anyoku, and I am a pediatrician by training. I serve as the Chief Health Equity Officer for Providence Swedish Health System in Greater Seattle area. And as we think about the story we just heard and how that plays out so many times in the lives of birthing people all over this country, we really have to ask what is the root cause of this problem? So the WHO defines health equity as the absence of systemic disparities in health and its determinants between groups of people at different levels of social advantage. To achieve health equity means that we close the gap between populations that have different levels of wealth and social advantage. And this definition is really important because it helps you to recognize that, first of all, the majority of the things that result in our health and our well-being happen outside of the healthcare system. But the healthcare system is where things come to a head. And so if we think about the social structure and structures that have been in place over many, many years that have resulted in us being where we are today, then we understand that to close the gaps in health outcomes, we really have to go beyond our walls. We need to understand our communities. We need to understand the historical, structural disparities that have been put in place, what the role of racism in medicine, and how structural racism has created these chasms. There's so many things that we have to understand, which we will not understand until we start to ask the questions. Sutter Health, I believe, is the health system in California that had this definition, which said health equity is giving everybody what they need to have optimal health outcomes. As a clinician, I know that health outcomes can be difficult sometimes. But when you're looking at African American mothers who have 4 to 5 times worse morbidity and mortality in pregnancy and birth outcomes, there's something systemically wrong. And I pause for a minute to talk about the difference between disparities and inequities, because we tend to use the terms interchangeably, but they're not necessarily the same. Disparities can occur because of of just biology. So if you think about the example I use, is the difference between the rates of breast cancer for men and for women. It is a disparity, but there's a reason for it. Inequities, however, tend to be as a result of more structural, more societal, more, policy issues, and therefore they are more unjust, and therefore they're areas that we should focus on. As a health system, we pride ourselves in understanding that we deliver the best care. And when I talk about delivering care, I think about access, experience, and outcomes. And so we measure these things. We've assigned value to a lot of these things to assess how we are delivering care to our various patients. The one big, we've known that maternal birth inequity was a big five-alarm fire in this country. In the wake of the pandemic, that there's so many other areas where we've now started to see how these long-standing inequities have showed up in different populations. And as a consequence, everyone is now saying, hey, what can we do to make this better? And so roles like mine have been created, and we're now having conversations that we should have been having many, many, many years ago. When we look at the graphics that you can see out there, if you just Google health equity graphics, and you see people standing on equal blocks, because as clinicians, we often say, oh, I treat everybody the same. I give everyone equal care. Is that really what everyone needs? Is that really addressing the needs of your patients, your individual patient in front of you? We heard in the story the role that fear played in this relationship. Because if you're in a space where the provider, the physician, is dealing with you, but not really paying attention to your unique needs, you might find yourself confused, not able to ask questions, not feeling heard, not getting the answers that you need to help co-navigate this journey of your pregnancy and birth outcome with your care provider. And so it's really important that we understand who we serve. So as a health system, the first thing we do is understand who are we serving? What populations do we have? Look at your data. Know who is in there. What are the breakdown by race, ethnicity, and language? Also by sexual orientation and gender identity, because you need to understand the full scope of people that you're serving and all the different ways in which people are othered. So understand the groups that you serve. And then what we do is look at, and what is prescribed to do is to look at your outcomes, look at your experience, look at your access in a disaggregated manner. Because when you do that, then you can see how the care that you intend to deliver is being received by the people you're trying to deliver it to. So by that I mean, if you think I live in Seattle, we practice in Seattle, and the African American population, for example, is 6%. If you look at our pregnancy and birth outcomes as a whole, it looks like we're doing great. Why? Because the African American population is really small. The indigenous American population is even smaller, and Latina populations is small as well. But when you disaggregate, so if you look at the whole thing as one number, you'll be like, oh, great, you have great outcomes, you have great performance. But when you break it down, that's where you see that 3 to 5 times difference that we talked about for African Americans. In Seattle, for indigenous Native American populations, it's actually 6 times worse. So, but you're not going to see that unless you break down the data and look at what do these numbers look like for each specific population. And that's an area that we focus on in our organization. And then once you've started to do that, you have to ask, well, what are the reasons for these disparities? Because we're not biologically different. A lot of the structure of racism was built on people given the false narrative that biologically different groups were different, but they're not. A lot of the difference in the way that people receive care comes down to bias, comes down to structural disparities, comes down to social determinants of health. And so what you do once you start to see those gaps in your area of influence is to ask, what are the reasons for these gaps? One initiative that we've just launched here at Providence Swedish is called Team Birth. And it really boils down to exactly what we heard about this in this story, which is forcing a process by which pregnant and birthing people are listened to. You would think, really, you had to put a process for that? As you've heard, it really is important because people are moving fast and talking, sometimes in shorthand. You've made an assessment, you've come up with a plan, and you haven't paused to share it. And one of the reasons why that is the case is that we're not thinking about the patients that we're serving all the same way. There's bias that comes to play in the way that we deliver care, whether we admit it or not. Every one of us has bias. And so how do we manage that in the care that we deliver to patients so that we're treating everyone equitably? So Team Birth, the intervention is, the grand total of it is a little chalkboard on the wall where you write the patient's name and you write their loved one's name. If they have a doula, you write that there as well. And when you come in as a physician into the room, you intentionally have a conversation with the people, you call them by name, you involve their nursing team, and you bring everybody because you're trying to force that process that will allow for people to ask questions and be able to address the concerns that they have. The other piece that we bring, which my team is building here at Providence Swedish, is that we're building a network of doulas. We call it the Just Birth Initiative. And we're building because our numbers are most challenging for the Black African American population and the indigenous population. And we know that doula care is an evidence-based intervention that can help improve pregnancy and birth outcomes for BIPOC people. So we're building that network where we're recruiting Black doulas and Native American doulas, training them and bringing them on board as part of the team. We're outreaching to the community to reach out to populations who we have seen from our data are underserved, and have a doula come alongside those mothers and walk them through their pregnancy, support them through their pregnancy, delivery, and after. Because a doula can help to bridge those gaps in communication, help to manage the fear and the anxiety that a lot of people, unfortunately, are going into pregnancy experiencing. So I just wanted to share a couple of examples of what we're doing in our health system as an example of trying to bridge these gaps. There's a lot of opportunity, and I'm so grateful that we're having this conversation.
So the problems that were just being described are real and they're tangible. And where Wildflower comes into this Wildflower is really looking to enable an improvement in health outcomes for all populations and to reduce the disparities in outcomes by supporting both the patient and the provider. And the way that Wildflower thinks about this is that we have to consider both the patient and provider and all of their needs in order to drive that an improvement in outcomes. And what we've done is we've created a solution that has both a digital component and a human component that integrates with the workflow of a provider in a practice and integrates into the life of the patient. The goal here is to improve health outcomes, not as the population, but for each and every one of the subgroups that was being described that experiences disparities in outcomes. And the question becomes, well, how do you actually do that? So the way that Wildflower thinks about this is that we think about this in terms of the determinants of health. And we've split the determinants of health into what we call patient factors, provider factors, and systems of care factors. The provider factors that we intervene on include things, as we were just discussing, things like communication, things like the diagnostic pathway, things like follow-up. And what that means is Can we help to answer questions that the patients have? Can we help the provider listening by capturing information from the patient and by providing that back to the provider? Can we help with implicit bias? On the diagnosis side, can we help with bringing more knowledge to the table by remotely monitoring patients, for instance? Can we help with the assessment of those data that are on the platform? Can we help with coordinating care and referrals and providing referrals or supporting referrals that are made in a clinical setting? When we talk about patient factors, we're talking about everything from social determinants of health, economic determinants of health, behavioral determinants of health. And what that means is things like, can we improve health literacy? Can we provide social support? Can we predict and maybe prevent or lessen the impact of mental health? Can we help support them in discriminatory practices? So as was being described earlier, race, gender, sexuality. Can we meet the patient where they are from a language perspective? Economic determinants are real, so there's financial insecurity, and so can we help knock down those barriers to actually receiving the care that they need? Financial insecurity crosses everything from food and housing to transportation. And then there's behavioral determinants, right? So what are the personal health practices and what are their coping skills of the patients? And how do we help them develop the skills that they need to actually receive the care that they should receive? There's also substance abuse, which is real, where we strive to both understand where a patient is, what those risk factors are, whether there's been diagnoses, and try to help the patients get the help that they need. And then the third bucket here is systems of care factors. And systems of care factors are things that are not necessarily in the control of the patient or in the control of the provider. And it includes things like, is care being coordinated across sites of care or across providers? Are there policies and procedures that are standing in the way of success here? Are there quality metrics that are important in a healthcare setting that we can help to improve? And so the way that we intervene on those determinants is by providing what we call an interventions framework. And it is comprehensive to all of the determinants of health that we were just talking about. So the patient, the provider, and the systems of care factor. The interventions that we bring to the table include things like educational content, content for engagement of the patient, trackers so that we can monitor patients remotely. We monitor patients with devices and with surveys. We provide risk assessments and escalations to a clinical setting, customer advocacy. We also provide a patient summary for providers. And so, again, to bridge that gap in communication, we try to collate all the data, all the information that we're getting from the patient, all of their interactions with both the digital platform and the human services platform. All of that information goes back to the provider. So the provider is stronger in being able to understand where that patient is and what their unique needs are. Provide dashboards for reporting, clinical decision support where it's appropriate, and help to do things like coordinate care and navigate benefits. And then we also bring a third-party network of services to the table. And so there's lack of access to care in many pockets of the US and or lack of access to timely care. And so where there is a need and there's not availability of in-network services, can bring things to the table like virtual MFM, virtual OBGYN services, genetic counselors, medical geneticists, mental health professionals, lactation support, et cetera, et cetera. And so that is a framework that we deploy to all patients, regardless of whether they're experiencing disparities in outcomes. And the question becomes, how do you take all that and use it to create a platform that drives health equity? And the answer there's multiple prongs to the approach, and bringing it all together in one comprehensive approach that really is designed to enable health equity is super important. And so the way that we think about this is that each and every patient has a unique set of needs, and those unique set of needs can be described by social factors, demographic factors, clinical factors, and what we call the patient activation measure. So how capable is a patient of actually receiving and the healthcare that they need and doing the things that they're supposed to do to enable that success. And when we talk about a personalized journey, we take into account all of those factors and roll that up into how we deploy our digital solution and how we actually deploy our human services personnel. And so the solution assesses risk based on sociodemographic and clinical factors. It provides patient-centric devices and surveys based on those risks. It personalizes the digital and human interventions based on all of those things we just talked about. So it could be personality, it can be demographics, it can be the readiness to change profiles, in addition to clinical information. So it doesn't just stop at the clinical information. It supports access to social services to enable patients to accept those interventions. And the solution actually improves access to care by providing virtual services to augment local services or to fill gaps in care. And it directly addresses racism and implicit bias through education and clinical decision support. And so what Wildflower has really strived to do is to, as you just heard the stories of the patient and of the provider / the health system, we strive to enable success on both sides of that fence. And so really our goal here is to help the patient and the provider do the things they're supposed to do, hear the things they're supposed to hear, see the things they're supposed to see, so that together we can actually drive an improvement in outcomes and reduce those disparities as a team. On the back end of all of this, and it's super important, as was discussed already, to be able to measure your impact. And so the things that really need to be measured are across the board. Are you activating, retaining patients and providers on the platform? How engaged are those patients and providers with our digital solution and with the human services that we provide? Are we adhering to care plans and guidelines that care plans on the patient side and guidelines on the provider side? Are we improving the health and economic outcomes? So measuring everything from leading indicators that starts with, is a patient adhering to the care plan that they've been given by their provider? Moving all the way to what is the rate of complications such as infection, gestational diabetes, depression and anxiety, preterm labor, all the way to the actual outcomes that we're interested in, that includes things like severe maternal morbidity, fetal and maternal mortality, NICU admissions, preterm birth, et cetera, et cetera. And then also looking across the board at practice and provider efficiency. So where we began this is we look to support the patient and the provider. And many of the issues surrounding the practice of medicine today are, do they have the time to do the things that they do? And so it's really a goal of ours to make sure that we are supporting the provider and the things that they need support with, allowing them to do the things that helps them, that keeps clinical outcomes, that helps them improve clinical outcomes. There are also quality metrics that practices have to report against. And so another arm to all of this is not just measuring the things that I've talked about, but making sure that we're keeping in mind what are the things that they have to report out against that help us understand whether or not the care that's being delivered is appropriate for the classes of patients that we're talking about. And so those include things like timeliness of care, are screenings being done at the appropriate time, what is the utilization of different services, and finally, are we impacting health? Are we creating health equity effectively?
All right, so thank you so much for those presentations. Now we are going to be moving on to the Q&A portion of today's webinar. There is still time to submit your questions using that Q&A tab to the left side of your screen. That said, we have a lot of great questions already, and we'll get to as many as we have time for today. So diving right into our first question for today's webinar, how will we know if this is working? What are the metrics and how do we get to them?
I think the way we know it's working, where we're achieving health equity, is when we begin to see closures in the gaps between, with those disparities gaps that I talked about earlier. As we've gotten to get into practice and building the muscle of disaggregating data and understanding how our performance metrics show, are experienced in different populations, you first see that gap. And then as you start to put interventions in place, we can go back to that data and see whether the interventions we're putting in place are actually closing the gap. I bring in the underserved population, the BIPOC population, getting their numbers and outcomes closer to the majority. So that's the way that we start to see that people experience healthcare differently, and the data starts to show it. Society feels different about it. That's how we know it's working.
Yeah, I completely agree with everything that Dr. Nyoku said, and I think we have to be careful here because, as she was describing earlier in her remarks, is that there are many pockets in the U.S. where disadvantaged or subgroups that are experiencing disparities in outcomes, the percent of the population is actually quite small. And when you take it down to a specific health system or a specific practice, it becomes even smaller. And so you may not have enough power in your data to know if a program is working in a specific setting. And so it's super important that we join hands across health systems, across states, and try to tackle the problem top down using interventions that are known to work, and then measuring in bigger and bigger populations so that we can actually have power in the data that shows us whether something is working. And the things that are really important to us are for each of the subgroups that we identify, how many of the patients are actually receiving the interventions that are intended to drive those disparities down. So how many of those patients can we get activated into those interventions? How many of them can we retain in the programs? What is their satisfaction with the programs? How are they engaging with the interventions that we're putting in place? And then making sure that our data is not, that we're collecting the data and analyzing it such that we understand what it is about our interventions that are affecting the patient behaviors as well as the provider behaviors. And so it's not just about, it's not just about creating those subgroups and looking at what the outcomes are, but actually knowing what is and isn't working, because we won't get it right the first time. And so you have to have what we would typically call, in a health setting or even in wildflower setting, a continuous learning environment. So as you know, if I provide transportation to these people, can they get to their visits? Or if I'm surveying them more often for depression and anxiety, do I capture more of them, and can I get them the access to the care that they need? And so it's super important that we're monitoring both the patient behaviors and the provider behaviors. Is the provider listening in a way that is effective? Meaning, are they receiving the information that they're getting from the patient and responding to it? And then finally, on the back end of all of that is obviously, we need to measure the health and economic outcomes. That really gives us a measure as to whether or not we're driving down those disparities. But there's a whole bunch of steps along the way. And really, if we keep our information and our policies, procedures, our programs siloed, that it blocks our ability to succeed, because you won't ever be able to scale. You won't be able to know whether something is working, and then you can't scale it. So I know I probably went outside the bounds of the question, but I think it's really important here to understand that that we have to work together.
I actually wanted to add something, if I may, and that's exactly the point that you're making, because as we're doing this work, the partnership of the community that you're trying to serve is absolutely critical. So if we're focusing only on data, as the point was made, it can get very cold and dry. But this is about feelings, and this is about connection. And so the community you're trying to serve must be a part of the intervention you're trying to put in place. Nothing about me without me. Have a conversation and say, hey, we see that we are not serving you as well as we want to. What would be helpful? Because that way you're not, applying whatever it is we think is right, which history and experience has already shown us we don't get right. So part of how we know that it's working is when we get feedback from the community that it is in fact working, that they are feeling different about the care that we're delivering to them, because we're doing the solutions and interventions in partnership. So yeah, I really thank you for calling that, and I really wanted to put an exclamation point on that.
Actually, you were jogging my mind here, because going back to something that you said when you were describing the approach that you're taking within your own health system is, it's super important to, and I know I'm reiterating something that Dr. Nyoku has already said, but understand your patient population from a socio-demographic perspective. And what we really try to do is survey that population, understand for each subgroup what their needs are from a social cultural perspective, as well as from a language perspective, sexuality perspective, and then match our digital interventions and our human services hiring to best meet the needs of those patients. And so, as she was describing, it is not a thing that you build that is going to solve this problem. You have to have the people that are local to the people that you're servicing, to join hands with them and to provide the support that they need to improve outcomes.
Great. Thank you so much for those responses. So moving along to our next question here for today. So how do we create cross-industry collaboration to solve this important issue?
I'm going to let you go first, because it is a hard question.
Well, I think it is absolutely important that we recognize this question, this issue, as a whole society issue, right? It's, health equity, health outcomes, like I said, is only 20% of it that happens when the patient walks through the door.
Yeah.
So patient having access to health insurance requires them to have a job for the most part in this country. That's the way our health system has been built. So part of the intervention is making sure that we're putting, investment back into the community. So for example, at our organization, we focus on supplier diversity. We're spending millions of dollars on all kinds of contractors. How do we make sure we're serving the community? And some of those contractors are from our community, because if you do that, then they get health insurance, then they have access to health care, and you've started to whittle down some of the barriers. And if I think one of the things mentioned earlier was transportation. If you have a family who has to take 3 buses to get to you, can you partner with a transportation organization to get them to their appointment? So, because if you can't get them there, then the clinicians are sitting there going, this patient is non-compliant. While the poor patient is trying to take the day off work, get their kids home, take a bus, a train, and an automobile to get to you. Can you solve for some of those so that you can get the patient there? I can't as a clinician, but we have partners in the community who can do that. And so as we're going out, cross-industry participation is critical. I'll just give you an example of what we did with the COVID vaccine. When the vaccine came out, I live in the land of Amazon and Microsoft. Therefore, everything is super sexy and techy, right? So all the appointments were on a link where you had to refresh and keep searching until you found one. So if English was not your first language, or if you didn't have a teenager in your house like I do, those links could be pretty challenging, right? So we had to think about, how do we get these vaccines to the communities who are disproportionately affected by this virus, right? So we looked and we got partners who gave us Wi-Fi, who gave us, because T-Mobile lives here, so they gave us Wi-Fi, and we're able to go out and give records. Other partners gave us trucks, gave us, workforce. People, our partners across the industry brought the things we needed to allow us to go out into the community, where we partnered with churches, with the YMCA, and say, hey, these populations, we'd like to be able to get to them. So those kind of partnerships are things that we could not do alone as physicians, or as a health system. And so, so some of the work that Wildflower is doing, which I will let Dr. Parikh speak to more, is exactly the kind of thing we're doing. Because as I'm talking to doctors, they look at me like, are you serious? I have 5 minutes to see this patient. You want me to do what? And so, so being able to have partners who can make it easier for them to do the right thing, right? Give them the information in a phone where we have to be anyway. Give them a platform where they can connect with their patients and be able to do what they intend to do, right? We went into healthcare to help people, but we're trying to manage time and all sorts of other priorities. So having partners who can say, okay, I'll get you an app for that. I think there was a commercial that said that a few years ago. There's an app for that. I will get you something to help you to bridge those gaps, to collect information, to help the family have connection with you, is really important. And the last one I'd like to talk about is the importance of congruency for clinicians and patients, right? Having a diverse clinical workforce is very important to be able to serve a diverse population. Because if I, as an African American woman, walk into the clinic and I see an African American woman, there's a whole lot that I don't have to explain, right? I can say hello and just go right into it, right? But when I'm dealing with people who are not familiar with my background, with why my hair looks like it is, there's a whole lot that we have to break down before we even get to taking care of one another, right? So, but in our country, the minority population are minority for a reason. So you're not going to get to the point where you have one-to-one matches, even though data has shown that when you have congruency between clinician and patient, the outcomes are better. But when you have a more diverse workforce, the rest of the workforce that are the majority and that are not necessarily minority start to understand and build cultural humility. They start to understand that there's value in people from different backgrounds. So one of the things we've done in the space where I am, where we didn't have a really diverse workforce, we build partnerships with schools who can bring those workforces to bear with us. So we built a partnership with a historically Black college called Meharry, where we can bring African American minority clinicians to come do rotations with us. In so doing, introduce them to our system in the hope that over time they will want to become part of our medical staff. And in so doing, begin to diversify the workforce. Because when my colleagues start to meet people like me, when they first met me, they were like, they had lots of questions. But as we get to know each other, they realize that I have a different perspective on life, but my perspective has value because now they know me. And so when they see other people like me, they're like, oh, yeah, I have somebody who did X, Y, and Z. So it starts to make the ecosystem more friendly, less daunting for people who are minorities.
Yeah, and I'm going to go back to something Dr. Nyoko said when she first started just answering this question, the whole 20% rule. One of the best ways to improve pregnancy outcomes is to have a patient enter pregnancy healthier. And one of the biggest problems that we have is that the groups that experience disparities in outcomes are disadvantaged to begin with, right? They come into a pregnancy at a clinical disadvantage in addition to a socio-demographic disadvantage, or a clinical disadvantage driven by a socio-demographic disadvantage. And there's a lot of different reasons to that. Not necessarily the goals for this conversation, but if we take a look at our healthcare system and the way that it's designed, there's not really an emphasis on preventative care. I know there's a lot of conversation about it today. There's a new emphasis on making sure that people are able to receive preventative care, but it's really, in the grand scheme of things, a nascent conversation and drives you all the way back to the beginning, which is how do you provide a baseline level of healthcare that is a right for all people, and make sure that that care is delivered equitably. And it starts with really the payers in this country, regardless of whether we're talking about the commercial population or a population that's serviced by government programs, Medicaid and Medicare, having them reevaluate like how we actually assess risk and deploy services to these patients, so that we're thinking about more than just the 1 year time frame, and really paying for the things that keep patients healthier earlier. And so we need to really transition in the US from a system of reactive medicine to preventative medicine, for lack of a better way to put it, right? And so I think, as we're talking about this, the programs that we can put in place as a health system and the programs that we can put in place as an enabler, by bringing technology and services to the table, we can have impact together, but that impact doesn't nearly take us as far as we need to go. And so it's super important to keep the conversation going at a system level to drive the changes so that women are entering pregnancy healthier while we're fixing the things that we can have control over when they're actually pregnant.
Great. Thank you for those responses. On to our next question for the panel here. So, where does health equity fit into value-based care models?
I'll
Um,
let you take that one.
I'm happy to. So we believe that value-based care models, if approached properly, can be enabling to reducing disparities in outcomes. And the reason that I say that is that it really affords both health systems and enablers, if they partner and join hands, to redistribute funds in a way that supports the patients that need those funds the most, right? And so as Wildflower talks about a personalized solution, where both the digital experience and the human services experience are personalized to the needs of a patient, it means those patients that fall low on the patient activation measure, meaning that they are not enabled to do the things that they're supposed to do, would automatically receive more resources. Those patients that come in with risk factors that are higher rather than lower, that include social and demographic factors and not just clinical factors, would receive more support than those that don't have those risk factors. And so the solution really, because we sell it under value-based care and we have control over the resources that we're deploying against those patients, it enables us to make sure that the patients that are most in need receive the most dollars, for lack of I know it sounds cold, but they receive the most services to enable their success on the back end. And without that, if you're in a straight up fee for service environment, it's almost impossible to do that because every patient receives the exact same thing on the back end of it. And that just perpetuates the cycle of continuous like health equity problem getting worse and not better.
I would say that I agree with all that you've said, and I would also say, just to step back for a minute to level set the difference between value-based care and fee-for-service care, right? So it's become so much part of a lexicon that we don't actually pause to think, what is the idea? The idea is that you're giving value in the care that you deliver. You're not just seeing the patient to check off a box that you've seen them, you've done this procedure. You're actually looking, therefore, not just in delivering the care, but looking at the outcomes and the impact, so that you're then getting, value-based care is compensation based on you demonstrating that you have delivered value. If therefore you have disparities and inequities, then you're doing the same thing and you're hitting with a blunt instrument, but you're not getting the right outcomes for this subset of people. So if you have the health equity lens in the way you deliver care, then you're thinking about, how can I make this visit have the outcome in this population that is desired? And so if the patient is coming to your door where they have health literacy challenges, nutrition challenges, transportation challenges, solving for those will help you to demonstrate the value that you intend to value. So I think health equity and value-based care are actually twins, and they are both working in the same direction, because if you're just doing the same thing you do for everybody, it will work for everybody who doesn't have all those other barriers that have to be overcome. But when you think about an equitable approach to healthcare delivery, then your goal is to deliver value, and in so doing, you have to address all those barriers that patients are coming to the table with.
And taking us back to one of the previous questions, the question there was, you can't just improve outcomes at the population level, because each of these disadvantaged subgroups are small parts of this population. And so we've got to be really, really careful here that even in a value-based care setting, that the quality metrics that we're tracking and are rewarding against are aligned with our goals on health equity, right? And so it can't just be that the population has to have better outcomes. It really has to be that the Black maternal population has better outcomes, or the Hispanic population has better outcomes, or the Native American population has better outcomes. And so again, we get back into this conundrum where if you're measuring the success at the program level at a single health system, and those and those populations are small, can you have enough confidence in your data to know whether or not something is working? And it gets us right back to the beginning, which is we have to work together across health systems and across states and across payers, which drives a lot of other interesting conversations and whether or not there's transparency in data and whether or not we can standardize some of these approaches, et cetera, et cetera. But yeah, value-based care it really is enabling, but you have to do it right.
Mm-hmm. Great. Thank you. All right. So, Erica, our next question will be for you. And the question is, how much of your sister's experience would you consider to be directly a result of health equity issues?
Yeah, that's a great question. I do, just from my experience and from watching and just having like a front row seat of everything that she went through, I would say a large portion of it was right. And so I really appreciate the conversation that we've been having today and just listening in to Dr. Nyoku and Dr. Parikh. It's just, I feel like the driving force here and just the reoccurring theme or issue that I've been hearing is communication and listening, right? And so a lot of those pieces just did not happen. There was a breakdown, and not that my sister wasn't asking, but it was just an uninterest in, hearing what she has to say or the questions that she had to ask, right? And so I feel as if, and just from watching her, it's very difficult to advocate for yourself when you're not being listened to in the first place, right? So it's like you're hitting this brick wall, and this continuous brick wall, and just watching her go through everything that she went through, the phone calls that she's made, the phone calls that my brother-in-law has made on her behalf, the phone calls that I've made, the phone calls that my mother has made. It was this continuous cycle of just not being heard, right? And so I feel as if a large portion of the issues that she's faced, of course, just could have been, I'm not saying that her entire issue could have been completely different or solved just by communicating or just having an open ear or listening. But I do think a significant part of some of the issues that she faced definitely could have been avoided, which is disheartening to hear. The doctors that she had originally, um, you know, there are a lot of different things that I don't want to create a different scenario or option here, but I do feel as if there were, some personal or internal biases that people have. And so I believe that even before she walked into the room, right, when you see a subset of a population for so many times, probably internally form some sort of biases toward people, right? And then that kind of creates itself the environment that we saw with my sister. And so I do feel as if the entire situation or a large portion of the situation was completely avoidable and preventable. And so I appreciate that listening and communication has been, I feel as if has been a large part of the theme or part of the theme of today's conversation, because that is critical, right? And so it's not that, when a patient comes in or asks a questions or, offer or say, hey, have you talked to my current or prior doctor about, why my blood levels have been low in my sister's case? Asking those kind of questions is not necessarily challenging authority. It's just trying to get clarity for yourself and see, what may be the best option forward. And so I definitely appreciate today's conversation, but I do feel as if a lot of the things that we see that are perpetuated in her case, as well as people that I know and people that other people may know as well, it's completely avoidable and preventable.
Thank you. Thank you for sharing your response to that. All right, so moving right along to our next question for the panel. How do you ensure you are taking a broad and comprehensive approach to health equity so that you are supporting all groups impacted by the current gaps?
So I'll go back to data, quantitative and qualitative data, right? So quantitative data telling you who are all the population that you serve. That's where you have to start. Who is your population? Who is your community? Who comes through your door and who's not able to get through your door? So it's important to understand what the lay of the land is. And so you can get that by analyzing your data as a health system, by analyzing the data of your population from the Department of Health or whichever other government affair has data. But there's lots of data out there, aggregated in a way that makes sense so that you can understand who you're serving. Then have a conversation with them. How have we been able to serve you? What are challenges that you see? How can we be better partners with you? What can we do for you? So when you understand what the whole lay of the land is and you start to address the drivers of the differences, then you can start, because what the intervention I have to put in place to address hypertension control disparities in African American populations are different from those I have to do to address the same challenge in the Latinx population. So if I'm looking at birth disparities for African American moms, what I have to do with that group is different from what I have to do for the indigenous moms. So, but I cannot do it until I know who I'm serving, where the gaps exist, and what the drivers of those gaps may be. So data is critical, quantitative and qualitative.
Yeah, I don't actually have a lot to add to what was just said because she's right on, for lack of a better way to put it. Like, we have to understand what the needs of those specific patients are and what the needs of the specific providers are that service those patients. And then we have to design our interventions based on that understanding. I think the only thing I would add to this conversation is that as health systems are collecting this information, and as we, as an enabler of this success, so in industry, are collecting this information, we hold patient fit focus groups, we interview providers either individually or in groups. All of that information, it goes back to this conversation of democratization of the data. So can you get access to the information that is out there on a region by region level? And so as for a wildflower, like as we go into a new region and we service a new health system, the first thing that we have to do is go learn about the sociodemographics of that patient population. And we start by asking the providers that we're working with. We try to get in front of the patients, and we have to do that over and over and over again. And we don't have the capability of leveraging the information that's really already out there because it's not available to us in a way that supports success. And I would say the same thing probably happens with the health system, where they don't get the information that we have or industry collects in general in order to support their own programs. And so, as we talk about democratization of data, and the conversation is really limited to what you see in a payer setting, you need to expand that language to include things that are outside of the payer setting. So the information that the health system has, the information that what I'll call the product developer has, the information that the payer has about the patients and the providers that we're servicing, democratizing that is what really needs to happen so that everybody is starting from a common understanding and we can leverage the base of information that already exists rather than having to recreate it over and over again.
Great. Thank you so much. All right. So it looks like we have time for just one more question today. We had a lot of great questions come in and unfortunately won't have time to address them all. So if you submitted a question that we were not able to address during the live Q&A, we will follow up with you personally after the webinar. But diving into the last question for the live part of our Q&A here. So how do you effectively make the case for health equity within an organization, particularly among leadership, to get the support, resources, budget, etc., needed to advance in this area?
Health equity is a moral, mission critical, and business imperative. And we can tell that story effectively, ever more so today, after the syndemic that we've just been through the last 3 years. Health systems understand that and, have risen to the occasion by saying, okay, we really need to do things like create a chief health equity officer position because we understand that there needs to be an organizational focus on this work. But, we know because healthcare and society challenges keep coming, right? We're constantly fielding incoming, and we don't know what the next thing is coming through the door. But as we get into this body of work, it's important that we are documenting our stories We're documenting stories of patients whose lives have been impacted by lack of equitable healthcare. We're documenting the stories of people whose lives were able to change and impact positively because we did this work right. We are in healthcare to help people. That's why it's a mission imperative. It is a moral imperative. It's not nice to have. But we also know that we have to keep the lights on and the doors open. And when you give better preventive and equitable acute care to patients, you actually lower the cost of care. Because if you don't care for people properly, or if you don't have good outcomes, then you have a patient that bounces back 3 and 4 times to take care of what could have been taken care of in one visit because you did not, we didn't have optimal, equitable approach to healthcare. So you can make the case either side. And I think leadership and organizations have heard this loud and clear. If they haven't, I am happy to chat with them. But this is not a nice to have. It is mission critical. It is a moral imperative. It is also a business imperative.
Yeah, and I would agree with everything that Dr. Nyoku has said, that it is an ongoing conversation that is getting louder day by day. And so there's not a lack of understanding that this is a problem, and there's not a lack of understanding that it is a problem that needs to be resolved, and that everybody has what she just described as a moral obligation to solve it. I think the challenge here really is the how, right? How do you make strides against the problem that we've been talking about today? And the how is complicated because you have a lot of marginalized groups. You have a lot of different types of problems that are specific to each group by region. And so, again, making sure that everybody is aware of those differences, and designing your programs and your interventions to be specific to them is super important. And so I think the conversation that's missing here is, how do you boil the solution set down into something that's simple to understand, that helps the leaders in these organizations believe that they can actually be successful in doing these things, and helping them understand that there is a tool set that we can use to get started. I think are the two pieces that are really required here.
Great. Thank you so much. All right. Well, I would like to thank everyone in our audience today for attending this Fierce Healthcare webinar and for submitting so many great questions. I'd like to thank all of our speakers for participating and Wildflower Health for presenting today's webinar. This webinar has been recorded, and you will be able to access that recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.